surgical So this is a surgical patient with bags, hollows, skin laxity. I simulate the effect, the potential effect of the G point. This is the realization of my surgical procedure, and it seems to hold. That's the question. So this is the patient before, and this is the split face result with the right side treated, the left side to be treated. If we look at the result on the right side, we see that the lower lid is shortened, the cheek is elevated, and transition is improved. So it's getting there. And this is the 6-month result of the patient that you saw the split face. So it actually seems to be. So you will see me injecting with a high G prime filler in order to achieve structure lift and support, and low G prime for the transitions. And we'll talk about the filler. So this is in the not medical literature, is just in a throwaway paper, but is a prime paper described as a G point left, and then also in the literature. The technique is complicated because it relies on bolus injection, half bolus injection, bridging injection, the tear trough. So you will see me doing it. So don't worry about that. So again, sorry for the duplication of that slide. Here is the G point. How do we find the G point? From a nasal, out of the nose to the tragus, from the corner of the mouth to the corner of the eye. We draw a bisetrix there that encounters a tangent that comes from the corner of the eye. That meeting point where the two lines form a 90-degree angle, that is the G point. Then I draw the defect. It's a V, considered as a V deformity, so I draw both arms of the V. They meet at the deepest part of the meat of the cheek in the apex of the V deformity right there. And I also draw the upper limit of this triangle, which correspond to the inferior orbital rim. I palpate that. And here in the paper that we just published, again with Gabriela and Cotofana, where do we go into in terms of ligaments and injection? And we'll see the drawing you will see on the live patient here where I find the G point. Then the drawing of the defect, the V deformity. Sorry, we'll come back with a new, fresher marking pen. Here is the orbital rim drawn. Here my entry point, and here I mark also the points where I be delivering my bolus, microbolus, the bridging, and again here is the injection technique that we're about to see. So I don't want to spoil that to you. We'll skip that. But we do use two different fillers here for high G prime. I use RHA4, and for the second part, I do use Redensity 2 because it's basically the most important filler as being up to now the only filler dedicated to the infraorbital region. So you will be seeing me doing this. I don't want to take any time off the live injection, but you will see me doing exactly what I'm doing here, and I'll explain you what we try to do. Here is a courtesy of Sebastian Cotofana's slide showing the placement of the filler relatively to the orbital retaining ligament in the axilla of the orbital retaining ligament in order to open up the angle of the ligament again that has been closing with the time and the atrophy of the medial the facial fat atrophy. Here is the ultrasound demonstration of the filler position relatively to the ligament. And again, here is on the cadaver dissection after injection of a color filler. in the ligament. Here is the injection across the valley of the tear trough. Here I'm on the nasal side with the tip of my cannula. Start nasal side, delivering the filler right now, coming across all the way. That's a bridge of filler in one position. And here we'll see the placement of the blue filler in the orbital retaining ligament, the pink and the green filler in the tear trough ligament. The pink filler is being injected with the cannula. That's the same way that you will be seeing injecting here. The green filler was injected with straight down on the bone with the needle. And both they are positioned at the same level, the same depth of the orbicular of the tear trough ligament in the muscle, because there is no other space there between the muscle and the bone. And also, we like to evaluate our results. In the paper that we published in the Journal of Cosmetic Dermatology, we were able to demonstrate at 6 months statistically significant reduction of eyelid height and similar statistically significant 6 months post-treatment result of mid-cheek elevation. Here is the demonstration of the before and after at the cam field picture. You see the recontour image is the highlighted here is the post-treatment, and you see the highest point of the mid-face is much higher after treatment. This is what is called lift, because this is a lifting effect, it's not feeling. And this, you see the cam field giving you the sense of feeling of the tissue, not the lifting of the tissue, not the feeling. Again, the vector at the cam field showing in the lifting effect. But if I look at my clinical result, this is a before and after of a patient of mine, and you see good results. But if we want to look at this more critically, on a side view, why is the lift here? Draw a line from the corner of the eyelid to the orbital ring, and then from the lateral limbus to the from the lid, but at the lateral limbus from the orbital ring before the treatment, and then draw the same lines from before and after treatment. The clinical defect, and you see the reduction of those lines is huge. It's very impactful, and you see it again. The defect highlighted here at these two reference points before and after, and you see how shorter are those lines. So you see that you're getting a mid-face elevation effect. It's not real. It's not moving the tissues up. It's just translating into a lift effect and a shortening effect on the lower lid. Again and again, you see that the lower lid is much shorter after the treatment. Here is to show you over-injected mid-facial patient and not got into the right places, showing even worse demarcation between the eyelid and the mid-face. After me revising it, you see that it's not more filled, it's just more lifted, and the defect has been erased. So if you want to see fresh daily result, you go log in to my Instagram. Welcome to see you there and interact with you and get your question. But Instagram is also important because results are delivered through an ATP approach. ATP for R, for results. And also Instagram is important because it's the goal that the patient have in mind when they seek this treatment. They want to look like if they had applied their Instagram filter. And they want to be able to show themselves on Instagram without using filters. So no more, no less. Surely no more. They want to look very natural, statically, and not only Instagram now is TikTok. They want to look dynamically good. So it's not enough to show before and after like this statically. You want to be able to show a before and after dynamically. Show that with this product and this technique, you can get a mid-face, full mid-facial improvement and focus on the dynamic folds of the face, the nasolabial and the infraorbital, and be able to erase those defects statically and even dynamically without altering the expression of the face. So let's see some more before and after. with this using the technique, and various indication between being dark circles or bags, or most of the time is a combo. And the patient come in nowadays in order to get surgical results, but not surgical procedure. So you see, this guy could have been a surgical candidate. This is a year after using the filler. Patient comes in for a check, and I do not only see a better infraorbital volume situation, but also the position of the lids is better 1 year after than before, as the patient has less scleral show after injection. So there is a role onto that, and I'll mention that also. Again, this is a typical, not tear trough, but dark circles is the full orbital malar hollow, and this is the before and after. The patient has really changed. But as you see, she also had bags, and she has no bags afterwards. Also beneficial onto the skin. You see this patient before, she's getting to be married in 2 months, and she has some dynamic fold and this excessive skin and skin discoloration as well. And after the treatment, she looks like it's being stretched. And if you look at the skin, also the colors and everything, she seems very rejuvenated and ready to be married. More happily, especially for the pictures. Again, the lack of volume in the infraorbital region brings also looseness to the skin. Not only the defect itself, volume, the hollow, and the bags, but if you bring back the correct volume, that volume holds up the orbicularis and the skin as well, and they will improve statically and dynamically. And we are working with other colleagues. It's a spoiler on a paper that is being under revision in PRS for correction of eyelid retraction. Sorry again for this Italian wording here, but where we try to unfold the lower lid all the way across to correct the eyelid retraction, as in this patient. And you see, this is way off label, as we are above the orbital rim injection. We are, very superficial and very, almost at the pre-tarsal orbicularis. I don't want you to learn this. I want you to look where you can go with this product if you need to do some crazy stuff, and how well tolerated these products can be. And you see the correction of the eyelid retraction before and after using this technique, bringing back the volume in the right position. This is another patient on the right side, complicated. You see the lack of volume, a couple of millimeters of residual scleral show on the right side, and you see after feeling that hollow there is not just the correction of the hollow, is that the eyelid is now touching the iris, so you don't see any scleral show, and the position of the patient is just the same. And again, another patient with a difficult cicatricial ectropion. She needs surgery, of course, but this is also after the filler. And here we injected 1 cc in each side. So it's kind of extreme. Do not think of that, but that's some of us are working on that as well. Thanks to the technique, thanks to the products, and the anatomy, the knowledge of the anatomy. So with these results, what I do work as a surgery only patient. So where are my no injections patients? When I do see excessive medial fat prolapse or excessive skin laxity and very severe eyelid malpositions. But bags like this, medial fat bags especially, is very too little space between the eyelid and the nose in order to get a nice feeling and a good result of the area. This patient goes to surgery, transconjunctival fat transposition, and she will be looking rested and rejuvenated for the next 10-15 years. Similarly here, this patient, big bags, especially nasally, also sad look to entire face. I do not waste an effort of injecting her. I do surgery on her. In this case, I did an endoscopic facelifting, transconjunctival fat grafting, and this is the result. Another patient that is contraindicated for injections here is a patient with big bags, but not only with malar festoon, and this is the malar festoon. Here is asking for a complication. If you inject her, you will not be getting any result. Send it to a surgeon or do surgery yourself, and this is the kind of result you want to get this patient onto. And again, another skin. I could have done even injections here, but sometimes surgery is about not only the lower lid, but this the entire periorbital region. If you just even if you did a nice work onto the lower lid, eyelid cheek transition, you would still get upper droopy brows and lids. So here again, the indication was surgical, full mid-face face rejuvenation with endoscopic surgery, upper bluff, lower bluff, and this is the kind of result you can get. So with this, I think ATP is very important. Let's conclude this talk with the last two pictures, slides dedicated to the importance of products. And is by showing you that I've been using other products before this one, and I cannot get the same result. This is the wife of my dentist before the treatment, and this is after the treatment. It's getting worse with bangs. I did the same thing. She was looking great at the time of injection. This was done live on a live show meeting like today, and she looked great. But at a week or a month, actually, I had to hyaluronidaze her. And then think about it. Again, another patient of mine used the same technique, different products. I will not say which products, but this is dentist as well. And this is, again, me having to inject her with hyaluronidase, and they retreat her with the right products, and she got the good result with no complication. So with my technique, I'm connected to this product because I can bring good results using those products only. Compared to, let's start again the slide. Sorry, I wanna bring it back. Sorry, and this is my very getting to the last slide. Because using this approach, I was able to deliver surgical result using a non-surgical. Sorry again. For using a surgical result using a non-invasive technique, meaning it's 20 minutes and they look like if they had an operation. The results are immediate. There is minimal to no downtime and a very long duration. For me, this results last a year or longer. That's why the G-point lift technique for me is becoming a strong competitor of my surgical practice. So my patient wants to look the way they want to look, but not having the surgery. They want to have an injection. So, again, thank you for bearing with me all during this presentation. Your questions are really welcome at any time. You write them, and sooner or later we'll be able to get to all of them. If we cannot do now today, just write them on any way you can. Instagram is a very nice way to get connected. Thank you very much, and we'll be ready to start with the live injection in a minute.
Hi, Dr. Bernardini.
Can you change? See, hi, camera. Yes.
Yes, Dr. Bernardini,
Yes.
thank you for that lecture. Very, very nice. Always. Oh, yes. Of
Yes.
course, we have to.
This is coming up. This is my background, and just to give you a sense from the view of Genoa, just to position in. Okay, let's back to me. Yes.
Of course, Dr.
Thank you, Jack.
Bernardini wants to share with us. He's really practicing in a beautiful clinic and really treating beautiful patients, right? So Dr. Bernardini, just before I let you go to the live demonstration to share with us your magic, we have a few questions that came up from the lecture. I'll go to the first question. Now, you mentioned in your lecture that it is important that, just a minute, I have my timer, sorry. Yeah, that was your timer for the lecture. Now, Dr. Bernardini, you mentioned just now that, it's important to address the lateral aspect of the cheek before you go to the medial so that you can use less product. Now, in Asians, we know that, we have very wide zygoma and we have very good volume laterally. How does that affect
I unfortunately here in Genoa or in Milan, I don't have a big Asian practice. Actually, very seldom, but that's how it is. But from what I know about my Asian patients, is that the infraorbital region is one of those anatomical areas that are really are universal, like across racial, across sex, across also even ages, because you can get that defect, infraorbital hollowness, dark circles, teardrop, call it as you wish, or bags, as a very young age, and even when you're a teenager. And the same thing applies for strong cheekbones populations such as Asian. And the model I had today that I selected for you, besides being very beautiful, as most of Italian female population is, just to be fair, but she is kind of closer to the Asian features, as we'll get a closer view to her in just a second. She has a very strong and high cheekbones here. I've already marked some of the anatomy there for you. Probably you need to turn that off. So I'm not sure that light, but or the thing is, she has a kind of a strong and very high cheekbone, very beautiful mid face. So by the way, Serena is a beautiful blue-eyed model for me today, and you'll be impressed to hear that she is 48. Am I correct? Okay, I would have guessed 38 at least. So as you see, she has a beautiful mid face because of the big gives support to the entire mid face. Yes, but as soon as she relaxes her smiling, you will see even with a strong cheekbone, you do have some infraorbital defect. And you see it from centrally here to laterally here. High cheekbone and then lack of volume right past below between. So here in the lateral aspect of the infraorbital area, what I wanted to do, if the technical team will allow me, the better way to introduce you to the patient is just by projecting the pictures that I have prepared on my screen. So if you can get me back to the computer mode, I'm going to show you what we have here. Jacqueline, do you have more questions, or do you want me to describe what I see?
No worries, Dr. Bernardini. I think you carry on and we take some of the other questions at the end of the injection session.
Okay,
Yeah.
as you see here with a better lighting, because with the camera and the pictures it's better, the pictures are always better. I was pointing out that she has very high cheekbone, strong cheekbones. It's much less like the Asian, but yet she does have a full infraorbital hollow that highlights some aging or tiredness to the eyes. And if you look at the side view, that will become even more apparent, that you need to restore, to reconnect the cheek to the descent of the ligament here. Here is where you would have the teardrop ligament here, starting the orbiter, retaining all the way across. She has a little tiny fat prolapsing here, and on the worst side, which is the left side, she has the nasolabial fold formation. And again, similarly to the other side, we do have the similar defects here. So there's not much space else for her to be injected in her entire face, other than the infraorbital and a tiny bit of the nasolabial. And this is, in my opinion, this is more or less like what can happen in your Asian population as well. So this patient can relate a lot with what your physician over there might be dealing with every day. So Jack, how do you want me to do it? Take more question or get into the anatomy highlighted here? Now you can eventually bring me probably the light. I take that light. Yeah. Uh, yes. Okay. Yeah. Okay, that's beautiful. Okay. Can you see well?
Yes, we can, Dr. Benedini,
Okay,
very well.
and okay. So I already just for the sake of time, I already preparing the anatomy. I'm gonna discuss with you, and then we have a completely clean side to for the preparation there. So here we have in green, I highlighted the ligament of the orbital retaining tear trough and orbital retaining ligament. Here, the zygomatico-cutaneous ligament. Here, I mark the landmark of the lateral line of ligament. So the temporal line adhesion, this is the lateral bicollar thickening, this is the zygomatico-cutaneous ligament, and finally this is the mandibular ligament. So this is the lateral line of ligaments. So we'll keep that in mind because the G point will be outside of the lateral line of ligament. And by injecting laterally to this point here, what we want to achieve a stretch to the ligaments, to the orbital retaining and zygomatico-cutaneous ligament indirectly in order to achieve an improvement already in the center of the face. Here in white, I highlighted the deep fat compartments, the medial fat compartment, the lateral fat compartment, sorry, the medial SUF, the lateral SUF, the deep medial fat compartment, the deep lateral fat compartment, and in red, we did highlighted some of the arterial, the vascular landmarks. Starting with the most famous, the facial artery comes off the anterior face of the masseter muscle, comes up toward the corner of the mouth. Here gives some branches, labial, upper labial, and then runs up to become an angular artery again, giving various branches. Here, up to this area, the artery runs deep, so it's very deep into the bone. From this point on, where the transverse facial ligament is, the artery becomes here superficial or intermediate, but here is the superficial. So superficial from up above and below is deep. We need to keep that in mind. Other arteries that we mentioned during the lecture, infraorbital artery comes off 1 centimeter or zero point 0.7 at the mid pupillary line here. So I palpate here, I can kind of felt a notch. So this is the artery. Remember, she does have a labial artery, she gives origin to the labial artery, nasal artery, but the first branch is the palpebral artery, the one that goes up to become palpebral and give origin to the palpebral, the peripheral palpebral arcade, and eventually the marginal arcade. Okay, so various branches of artery comes off there. Okay, here we do have the malar eminence, anterior and more medial to that. I felt another notch. This is the notch of the zygomatical facial artery that also gives branches that reconnect and forming the palpebral arcade. Why is this relevant? Because this connects to the transverse facial artery. That is a branch of the the external carotid circulation. So here, external carotid circulation, here is a branch of the internal. This is external carotid circulation is a branch of the internal. So external and internal circulation meeting these 2 points. So a risk for blindness. So remember, infraorbital, palpebral, zygomatical facial, sorry, uh, and what else? I think we have all drawn here for you. So on, let's on go to the, yes. We go on to the preparation of the clinical preparation. So we work on the right side of the face. say that I want to find the G point, right? So tragus, out of the nose, connection, corner of the eye, corner of the mouth, then a line that comes, that is a bisetrix, that meaning that cuts this angle into exact 2 at a 45 degrees angle. That comes up until it meets a tangent coming from the corner of the eye where it forms a 90-degree angle. So the G point is right here. Now, what else I do, Mark? Serena, bravissima. The best patient. Look up for me. I mark the defect. The defect is a V deformity, so the medial arm of the defect, the lateral arm of the defect. They meet at the apex of the V deformity, and I mark this point. So we do have the G point, the V point, then I mark the upper border of the orbital rim, which is right about there, okay? So that is my superior limit of my injection. My plan, my entry points are the G point, this will be the second point. The first point will be right about where I see the inverted V triangle of the smile, which is about here, okay? So this is my entry point. And if you look at my entry point, would correspond to the apex of the deep fat pad compartments, which is a V-shaped distribution. So I think it corresponds to that. But I look at clinically, it is right, my entry point is right here, okay? So from this point here, I have access to all the areas of the infraorbital and eventually the teardrop, so of the nasolabial. So in a patient like that, if I had to prepare for my injection, so here would be a bolus, here would be a big bolus, then all across I will be planning on my half boluses. It will be all under the orbital rim, so it will be not in the eyelid, so well below the orbital rim. So I do, this is the macro boluses are 0.1. This half bolus will be 0.05. Here I will be injecting 2 or 3 bolus of a third, 0.025, okay? Then there will be, what else? Again, as anatomy, we do have the ligament here, the teardrop ligament inserting here. From here on is looser, is the orbital retaining ligament is much looser, okay? So what else? We are ready to start with the injection. So we keep the anatomy intact for the moment. We'll clean up this, we start with this and we move along. Okay, yes. Grazie, open it. Any questions for now? All clear? All?
Yes, Dr. Bernardini, it's all very clear. Could you share with us what products you will be using to treat this beautiful patient this evening?
Yes, I'll be using RHA4, and I'm opening now the boxes, and Redensity 2. For the phase 1, I'll be using RHA4. For phase 2, I'll be using Redensity 2. I'm gonna loading up my syringes so to have everything ready for me. It's just I do at the very last minute because I don't want any contamination if possible. This is my the patient has been already cleaned and disinfected. So For me, we get the entry point. As I mentioned before, I do use a cannula all the time. I do not use all the time this type of introducer, but this might be convenient for some of you. So this is sometimes, sometimes you know when you make a hole with your needle, the hole is difficult to penetrate with the cannula because there's not enough space. This is easier because you point the cannula inside the channel of the introducer and then you're already inside. There is, and then I do not pre-inject the entry point with local anesthesia. So I enter in the superficial fat compartment, and my gliding plane is superficial.
Chứ còn này tại vì mà để mà cải thiện một cái làn da xéo mà về một cái làn da bình thường thì nó khó. Tương nói chung là
Okay, so my gliding plane is superficial, and I get to the point of injection, the first injection, to the first bolus. Can you see me pushing on the cannula up to show you the bouncing? You want to give us a little more zoom to the... Okay. If you... So here I deliver a 0.1 cc of product. So I'm going to hold my syringe still, look into the marking there on my syringes, my syringe marking, like here, start 0.12, and I will not move until 0.11. So that is my first bolus. It's right here, macro bolus at the G point. Then I go centrally and I do the same thing. Superficial, I slide superficial, so it's less painful or not painful at all. And you see it slides very well. So Serena, is it painful or not? No. So we don't have much pain until now. So I get to the first point of injection here, you see, I'm pushing on it. So Serena, pushing down. Okay, perfect. Okay. You see, it's below my orbital ring. I go deep in that point and I deliver in the white 0.05, so half of a bolus. Then I come down at the V point, at the green mark, and at that point I inject 0.1 cc, and I do inject a little more below, at the white point below the green point. Okay, so this is...
Em năm nay mấy tuổi?
Serena?
Thì phải chấm
Stai
em
svenendo?
thêm nữa là
No,
khi mà em mà
no, dimmelo perché devo, almeno faccio un po' di chiacchiera e ti... Hai sentito male? Ma stai svenendo sul serio?
Cái gói kia là chỉ là cái gói để
Okay,
trị liệu của kiểm soát
we do have a good time for some questions in this moment. As I give a minute to my patient because there's a little bit evaporating on me, and I don't wanna lose her. Yeah, so it's a little bit hot in here, so no, dobbiamo usarti con cautela. Per cui dimmi per favore come andiamo, perché io faccio dell'altro nel frattempo. Come stai? No, davvero, ma hai sentito male? E allora perché... Un po' d'acqua. Okay, we refresh our patient that is being sensitive. She didn't feel much pain. She was with me until now, but we give her a little second. And Jacqueline, we don't. Can you bring back to me just so it's a good time to give her a little rest of the patient, and I'm going to take back you to the view of general while you ask me some questions.
Yes, Dr. Bernardini, let's give some time to the patient. Sometimes they can get a bit
This
nervous.
is, yeah, this is the first time that happens to me on a live, so it's all interesting, and we really need to give her a little
Of course, yes.
space. Yes, I
Yes.
don't know what.
That's the beauty of live
Yeah,
injection,
yeah, yeah,
isn't it, Dr. Bernardini? Sometimes things happen. So why
yeah,
don't we
yeah.
go and take some questions? We have a doctor here who will ask, what layer do you put RHA4 in the G point? And then which layer does redensity go then in the tear trough?
Okay, we'll see because we're talking about mid phase and we're talking about infraorbital area. There is a complete, as you've seen before, these are two very difficult and different anatomy situations. So with the RHA4, I'm very deep in the G point and at the V deformity. I'm just above the periosteum. So I am at the in the SUF compartment, and I am in the SUF compartment on the G point. I'm at the medial SUF, lateral SUF in the G point, medial SUF at the V point. When I get with the redensity 2, when I get into the redensity 2, I'm under always one plane, just under the orbicularis muscle, and there is no other way of doing it. The plane of injection in the eyelid is always above the orbital septum, under the orbicularis muscle.
Right. And coming back to eyelid, doctor, we have a question about upper eyelids and brows. It's definitely not included in today's injection session, but can we ask how do you treat the upper eyelids and the brows if you do have a patient?
Yeah, the brows and the upper lid is similar because the brow is like the cheek, has a very thick tissue there, is the equivalent of the SUF on the brow would be the roof, a retrobicularis oculi fat. Again, a thick tissue layer with a big fat, and then you want to be in the roof or deep to the roof, just above the periosteum there. While if you get into the upper lid sulcus, which is closer, is just in the upper lid, then you do not have thick layer. Again, you want to stay under the orbicularis, deep under the orbicularis, because that's a very thin layer. And again, the upper and the lower lid are both similar situation of being very thin tissues with the bone prominence there. So it's very easy to have a problem with too much filler being injected into the area. Uh,
Yes. So I think just now maybe it wasn't very clear. One of our audience is asking at the G point, was it deep or a superficial injection?
the G point
Yeah.
is again very deep, is as deep as possible. Is not on the bone, cannot be on the bone. It will be deep under the at the level of the SUF, deep between between the fat and the periosteum.
Right. So a few questions around this. So Dr. Bernardini has clarified his injection at the G point is definitely done deep. Maybe from the way that you're watching, it wasn't very clear, but so that we are all aligned, it is a deep injection.
Okay.
Yes, thank you, Dr. Bernardini, for that clarification.
We are almost ready. Un altro bicchiere d'acqua, lei? We are almost ready to restart with the injection. I didn't expect the patient be
No, don't worry about it, Dr.
lighthearted.
Benedini. No worries.
She didn't feel a thing, and she became pale on me. Just so we really need. It doesn't matter. We are not rushing it. This happens sometimes. It's
It
usually the
does.
funny thing is that's happen all the time with men. So with men, I'll be not impressed by this happening. I'm very strangely impressed by female this age or this. It's probably she actually never had an injection before, so
Right.
this explains things. So,
No, Dr. Benedini, please don't make any apologies.
okay, no, no, no,
We are
no
very,
apologies,
yeah,
no
yeah, no
apologies.
apologies.
I make her a little more comfortable. Hai
Yes,
finito con l'acqua?
it's summer in Italy now. Maybe the room is getting hot. Everyone's in
It's a
there.
little bit.
Yeah,
There is a lot of people in the room. So
yeah,
we did inject. We get back onto her.
yep.
If se ti risuccede me lo
Là
dici
tiêm đâu?
prima e cerchiamo
Tiêm một
di.
bên
Okay?
hả?
We
Rồi tao
proceed
tiêm.
very slowly.
Là
Okay?
đi từ đây lên đây đúng không?
So, Serena, per favore dimmi se sempre va tutto bene. È un po' tutto
Này tiêm
così.
bên này hay tiêm
Non è
bên này?
che... Hai sentito male? Ok. Okay, so as you see here, again, diving deep. Cerca di stare con me. Sì, guardati intorno.
Đây của teoxan đúng không?
Parliamo. Okay, so I'm delivering small aliquots of filler in the spots where I pre-market before with my white. And my plane of injection, I want to reinforce
Đây lên
that
trên cái điểm này
concept,
hả?
is deep.
Vậy thì mình không tiêm vậy rồi. Mình tiêm vậy có mã cao quá. Điểm có mã cao quá. Nó là của người châu Âu thôi. Người Hàn Quốc, người Việt Nam nha, điểm có mã ở dưới này.
Respira, stai tranquillo. Sì. Okay, so sorry. I do about 10 of this procedure a week, so this is very unusual for me to happen. I'm never concerned with the passing out of a patient, female patient model ever, but I will be more.
Ở dưới này là dưới sừng, nhưng mà đi lên nó văng mắc cái vòng cung nó sẽ trượt lên được.
Okay, so you see me here on the medial aspect. We need to get a better angle. The tip of my camera is way up there, so I'm gonna stay deep. I deliver very tiny aliquots of products there as I come out with my cannula. So just giving support to the ligaments. Okay, so I didn't even look at how much he injected, but is it a good time for me to breathe, to respira, io tanto. Give me the camera because I want to show you that in the meantime I'm going to give a break to the patient, but we are at the time where we'll be switching products. So up to now, I've injected. Can you focus and zoom on the syringe? I'm going to show you the number. So this is about half of a syringe being injected for phase 1. So this is giving support to the mid phase, is indirect treatment. Again, focus on starting with the G point and the V lift, and then orbital padding laterally and medially, giving support to the lateral orbital retaining ligament and the tear trough ligament. Now, I put this syringe away, and I take the other product, which is Redensity 2. I prepare the syringe. I prepare to re-enter, and then I bring back my patient, but back onto the action. Okay, so at this point I clean up what I have drawn before. I only leave my entry point highlighted, the G point. I start looking at things, And I promise you, I will show you the before and after, comparing one side to the other. But this is already a good time to show the patient, you know, that she can appreciate or not any changes achieved so far. Even though we didn't inject much, it's just half of a syringe, she can tell that is already improved. Will be compared. Will be seen, be cleaned up in a second. So here, the second entry point. Questo lo senti, lo so.
Vậy mình
Scusami.
nó có cái kim đôi do gửi mấy bỏ vô luôn hả? Cái kia nó màu mè dữ.
Entry point is here at the G point. The gliding plane
Nhưng mà cái đầu
of the
cannula đâu rồi? Không thấy. Đây hả? Có đây hả?
is under the ubicularis. I'm going to stay as deep as I can under the ubicularis. And this is the first retrograde injection. Here I'm getting beginning of ecchymosis. Everything happens today. So that's a little bit to deal with. Too much anatomical explanation to the patient. She can't understand everything, so she's concerned about her muscles, her arteries, and all that. So she's really participating with me into everything that's being done inside. So again, I go back under the orbicularis, and I focus a lot on the lateral part of the hollow. You see the tip of my cannula is past the ligament already. I'm not injecting. I start injecting as I come back out. And the quantity of filler that I'm injecting is really minimal amounts per passage. My first part of my first endpoint is addressing the lateral hollow, the lateral part of the hollow, before going on to the medial part and the so-called, the proper tear trough. I want to address the lateral part. As you remember, by injecting lateral to the line of ligament, you get an indirect effect of stretching onto the connected ligament, which are the orbital retaining ligament and eventually the zygomaticocutaneous ligament. So here is me injecting. So far I've been injecting 0.3 cc. Com'è? Ah, ho visto chiudere gli occhi e ho detto la sto riperdendo. Ok, andiamo bene? Ok. Senza ridere, serena, tranquilla beata. Il peggio è passato, i dolori, tutto quanto. Okay, so now we're going, you see me here in the center, a small aliquot there, and now from now on, I will be going medial and addressing the tear trough by releasing small quantity of product as I retract my cannula. The technique is referred to as a bridging technique, as the idea is that of depositing bridges, small bridges across the valley of the defect. The bridges of the product will support the ligament and blend the defect. So if you look at me, oh, now things are really happening. I'm very happy with everything that I see. And I have 0.6 cc in my syringe, so it means that, to be fair, I'll be, usually my treatment is, 4 syringes per patient, which is 1 RHA4 and 1 RHA2. So I'm gonna, and I don't overdo it. It's 0.6 on this, so I have still 0.1 cc to go. I usually use the full syringe, so I'll be doing that, looking at every single detail remember, there is, even though it might seem that I'm superficial, I'm actually keeping the injection deep, always under the orbicularis muscle. There's no way that I'm ever above the orbicularis muscle. You see, I'm going all the way to the tear trough, all the way. I'm touching. You see the angular vein over there? Looks like I'm almost touching with the tip, but I'm actually here where I'm injecting. So, okay. In order for you to see, I'm at the level where I stop. Cambiami la camera, prendine una nuova, ce n'abbiamo 100. Per favore, please. Okay. I'm gonna do some massaging, not just to massage it. It's actually to feel that there are no any local bumps, lumps, accumulation. So this side for me is done. So I'm gonna, while I ask the patient to hold pressure on the entry point because it's a little delicate point, I'm going to clean up the anatomy on the other side so that we can get a better sense of what we did. The cleanup will be easy and quick. Regarding the anatomy, I'm always gliding my cannula when I come from here to here on the superficial planes, so well above the infraorbital artery and so on. When I pass the artery, which is about here, that I'm getting to here, then is where I change the angulation. Okay. Okay, now. Okay, so for me, this is first thing I do. I'm going to tell the patient, senza sorridere, guardati bene. Okay. Now what I ask you to do as a camera, and Serena, can you, okay, just perfect. Okay, straight into the camera. I don't know, guys, I have a difficulty in seeing the screen. Okay, the light is not, nice. Okay, thank you. Okay, so, like this is the treated side. If I have to point it out, that means that it's not clearly visible. Ho bisogno di, mi metti il coso. Perché, okay, so you see here, as we mentioned before, here we do see the bag, here the emptiness, here the hollow, here the if you look at the patient like that, you see that there are no the blending between the eyelid and the cheek is almost perfect to me. So, Jacqueline, I have a quick question for you. I'm already done with one side. I don't know if you have questions, comments regarding the, what we have achieved so far. You really, it's really nice for me to see. Despite the mishaps of the treatment that makes it even more exciting. Yeah, give me a big zoom. Senza sorridere neanche proprio uno. Ok? Abbiamo una difficoltosa luce, però. Okay. So
Dr. Bernardini, yes, I can see from
can
my.
you tell? Yeah.
Yes, we can tell the results are very significant. I don't know if you can see it from your screen. I'm sure you see it on her physically, but from my perspective, her tear trough is completely gone on the right side.
Yeah, it's it's the entire region that hollowness that is improved, and even the bags and all that. So I'm kind of pleased. I usually do as you like. I can do the other side or just whatever you think is the timing. I have lost track. Can you help me with
that? So no
that?
worries. Yes, of course, Dr. Bernardini. I think we will have to treat the patient's other side off camera because we do have some questions coming in for you, and we would like you in the next maybe 10 minutes to be addressing the questions, if you don't mind.
Yeah,
Yes.
I am more than happy to. So.
Yes. And we thank the patient. Thank you so much for accepting to be a
Serena,
patient.
grazie
Serena,
mille.
I'm sorry, Serena. I just remember her age because 38, isn't
She's
it?
she is amazing. Yes, she
She
is
is.
amazing. She's
Thank you, Serena. And we let her have a rest
okay.
and a drink while Dr. Benedini will
Ok,
address some of the questions and he will come back to
ancora un
you
po'
in a
d'acqua,
while.
ancora un po' d'acqua. Ok,
Yes.
camera a me.
Yes, Dr. Benedini, now you can have a seat
Yeah,
and
yeah.
yeah. And we can tell that you felt really bad about the incident just now, but really, don't be. We are still very
I was
amazed.
feeling bad for you because I
No,
didn't
no,
want
not
to,
at all.
but
Not at all. Yes.
okay, I'm ready. I'm comfortably seated, so ready to
Nice.
get all your questions. So
Yes. So, Dr. Benedini, there is some questions on the tools that you use. Okay. Can you comment? Was your cannula a 25 gauge 40 mm cannula?
yeah, the canvas. Sorry, I forgot to mention that.
No problem.
I do use 100% a 25G cannula, 50 millimeter long, because that is that's for me. There's no point in using a shorter one, as in the longer there is even the short distance. So I can't, like, but I like the longest. And the 25 has been the right size as for safety and as for pain. The smaller, the finer the cannula size, the less painful would be. But so some prefer the 27 for that, but the 27 is too small in terms of safety for vascular penetration, artery penetration. So 25 has been demonstrated to be safer, if not 100% safe. So we always need to keep in mind. That's why it's always a good idea to keep the anatomy on the non-injected side there, just to discuss where you are gliding your plane of injection relatively to the artery that you are brought to in evidence. But I feel very safe in using the 25 gauge cannula. Uh, Despite, what happens here can happen every day, every patient in your office. Usually this never happened, but the motion here can go on for the injector and for the patient. But that's how you deal with that. You relax the patient and get back to, that's a common situation. Patient don't feel a lot of pain, but they feel the cannula is it's not so nice because you don't feel pain, but you feel something enter here, come up there, you feel it poking, and then you do not know what's going on. Maybe a little pain, yes, but usually the level of pain is between, on a scale from 0 to 10, when I ask my female patient, is about 2. If I ask a male patient, is about 8. So.
That's a big difference between male and
Yes,
female.
yes.
And in terms of your bevel, Dr. Benedini, do you make it a point to put your bevel pointing upwards or down? Does it matter to you or not at all?
It doesn't really matter to me, but if I do have to make a point, I usually, before entering in the skin, I prime the cannula or the needle or the cannula, and I look at the filler coming out from the top of the cannula. Then I enter, and I think I keep the same. But I don't see what I'm looking at. It doesn't really matter where is going down or up. Where it matters is where you're in the plane and the level, the anatomical level. It doesn't really matter where it comes out or from. So
Okay.
for
There
me,
is
at
a
least.
right. There is a question for the second injection that you did. Was it with RHA4 or with density 2?
The first from the cheek down here up is RHA4 deep in the SUF, lateral SUF and medial SUF. The second injection, where I enter from the G point and I go all the way across the infraorbital region, I use 100% redensity 2, and the plane, the gliding and the injection plane are all the time in the only plane that we do have in the region that is below the orbicularis muscle. above the orbital septum. And that is the on, you know, you are in the right plane when you get into very easy with gliding plane for the cannula, the one no resistance is encountered.
And Dr. Bernardini, do you undertreat your patient like to about 70-80% to allow the volume to expand within the next 2 weeks? Okay.
No, I do not expect that. I tend to get to the point where I want, and usually I do not exceed those two syringes. Uh, Even though it might sound too much for the treatment for a tear trough, this is again not a tear trough treatment. This is eyelid cheek junction. So we're treating the mid face first because medial and lateral SUF do belong to the cheek, not to the eyelid. And we are, so it's not, the RHA4 doesn't count to treatment for the tear trough, if not for minimal amounts, just to give support to the tear trough ligament. When I enter with the Rodensity 2, I inject a full syringe on both sides, so it's half of a syringe, but is all across the distance of the from the medial to the lateral corner. So it's a very long, very wide, and very high area. So it does seem a lot, but it's actually most of the time I do not undercorrect. I correct it the way that I want. Ask the patient to come back at a month because I do tend to expect a 10, 12, 20% volume reduction at the month. So patient come back at a month, say, very happy, I'm going to stay. Or if they say, I like it at first when I was a little more full, then I can offer touch up.
So, Dr. Bernardini, if I'm not wrong, most of the time you can get this result with one syringe of RHA4 and one syringe of Redensity for the full face?
Yeah.
Okay.
This is the entire eyelid cheek junction, yes.
Thank you
Two
very much.
syringes is all I need, yes.
Okay, so this question is on your presentation earlier. Can you confirm that for superficial injections, even with a cannula, it will not lead to vascular compromise? It's hard to promise that, isn't it?
No.
With a cannula.
Why? For superficial injection?
Yeah, even with a cannula, you will not get a vascular compromise. Can you confirm that?
I think I made a point. Then people feel safe when injecting deep. Actually, I wouldn't be feeling so safe when deep. I feel much safer when superficial. Let's revise the anatomy that I mentioned before. The only superficial artery in the upper midface is the arterial and angular artery, which are very far, in my opinion, from the area of treatment. So the angular artery is, I see the vein, the artery is with the vein a little deeper. So it's not getting into where I inject, ever. All the other arteries, so the infraorbital, palpebral, zygomatical-facial artery and their branches run deep, attached on the bone. So if you inject superficial on a 3D anatomy, even though you be injecting onto right at the infraorbital emergency point, you are superficial, so you keep the artery way down below you. So a superficial injection there, for me, is safer with a cannula or with a needle. It doesn't matter. Cannula is safer than a needle. Yes.
Okay, so the point here is don't, because you are injecting deep, that you think you are safer.
Exactly.
That's the point you're trying to make. Got it.
Patient, that's why I want a listener to be very aware that most trainers, the gurus there, say that injecting deep is safe. Well, palpebral artery, zygomatical facial artery, infraorbital artery there are deep. So how do you feel safe? I don't know. I don't. So I would feel safer on the superficial plane.
And in the same token, Dr. Francesco, would you use a redensity tool for superficial injection in the tear trough area?
RH2,
Sorry,
RH2,
redensity. I'm sorry, doctor. I beg your pardon.
sorry,
Redensity tool. Will you use it for superficially in the tear trough area?
again, Jacqueline, superficial in this area, there isn't a superficial or deep. There is just one plane. There is under the orbicularis.
Yeah, so in Asia, we are seeing, and then we get some questions sometimes, like the doctors.
That's very good.
Yeah, after they put the redensity, they know it's a deep injection. They use redensity too deep, but sometimes we get questions from doctors whether it is okay to put a redensity too superficially, and how would you advise?
I have absolutely. So that question needs to be taken a little more into specific, because at the tear trough there is a muscle and there is a bone, but the muscle has a complicated anatomy, because the muscle is the gliding muscle, right? The dynamic, the muscle that moves and is covered by the skin. And then there is, under that muscle, there is the muscle that goes onto attaching to the bone. So when you refer to deep injections on the bone, you're referring under the ligament. But sometimes I do tend to inject also more superficially, always under the muscle, but not under the ligament, but under the muscle that glides. So you are always in the correct plane of being preceptal under the orbicularis, but we need to, define which level of orbicularis muscle, because we saw that the tear trough ligament, the orbicularis muscle, forms the ligament. So you are in the orbicularis, but in that case, you are deep on the bone, or a little more superficial, still under the orbicularis.
Okay, got it. Okay, so there is a question here. Dr. Benedict, can you summarize your G-point technique? Because I think we're seeing a lot of things going on. If you can summarize it, how would you do it?
It's very simple, because that's one bolus, big bolus here, one big at the G point, one big bolus at the V deformity. All the rest are half boluses lateral between these 2 points, with the same products coming from the midface to support the ligament, and even 2 or 3 bolus here again to support the ligament with the same product. So it's orbital contouring, orbital padding. 2 points, lift, you need to give lift and support, then padding, and then you go to the eyelid. Take the redensity 2 and do bridging. Bridging, you can do, like, if you, just to give you another analogy of bridging, to this defect, the nasolabial fold defect runs obliquely, like the tear trough. You enter here, address the defect like that, deliver streaks of filler that support the defect instead of injecting the defect. Because when you inject straight into the defect, many times what happens is that the product goes this side and this side, making the defect even more deeper. If you address it from down below and give support to the valley with all the way across with this bridges of fillers, then you bring the defect back more superficial. And eventually, fine adjustment can be done on the defect more directly. But I like to use the same amount of product. Most of the time is the same, half of a syringe one side, half of a syringe on this side, more distributed across the defect. Instead of having 0.5 of a product in 2 boluses straight down deep with the needle, that would not look good in my opinion.
Right. And if I'm not wrong, what you're doing is like a little bit of a cross-hatching and giving a bit more support to scaffold the tissues.
Exactly. Cross-hatching, but why the bridge? Because you need to have two stronghold or position in your, so once if this is the valley of your defect, my syringe goes on the other side of the valley, on the where the defect is ending. I start past the valley, bridges across the defect, and ends on this side, proximally, again, where the defect ends. So it's kind of laying, it's just position on the two extreme and holding up. It's not just, it's a little more than,
It's not as simple as just putting it where you
yeah,
see
yeah.
them. Yeah, got it. Yes, and doctor, how long in your experience does this treatment last for your patients?
What I tell my patient in my office, I tell them that this treatment lasts a year or longer. And I do have many patients that comes after 3 or 4 years that do still have a full result, and they wonder if it is normal to be still looking that good, and say, well, yeah, it is. I cannot promise that the average does last 2 or 3 years, because it's a little more unpredictable after a year, but it's very, very common to see a good result lasting much longer than a year. So when you do this, you're using a little more than just one syringe over a filler, half on one side, half on the other, but you're addressing more. You have a wider view of the defect. It's not the tear trough, is just what I refer to the eye cheek junction. That is in my mind the dark circle. The dark circle is a big definition. It's not just the color. It's the in full circle of the orbital malar hollow. It might include bags and skin laxity. So there are so many factors playing into role. So you're addressing them all. It's a better looking result. As we showed, is a more lift effect than just feeling the whole approach. So I like it a lot more.
And we agree with that. So thank you, Dr. Bernardini. Tonight we have a lot of questions, but with respect to the time, and of course we lost some time with the patient. So questions that we are not able to address this evening live with Dr. Bernardini, we'll try to get back to you after we have posed the questions to Dr. Bernardini. With that, thank you, Dr. Bernardini, for the time, and I would like to invite Krish to come back on to close the session for us this evening.
Yeah, that was a good dialogue, Jack and Francesco. Thank you so much for the time that you spent, not just during this last probably an hour and close to 2 hours, but the time that you and Roberta and the crew spent, and the lovely patient model. We appreciate your contributions, your support to make this educational event a very engaging one. To those on the call, a number of questions. Francesco, we had I think 375 people actually attend the webinar and follow the live demonstration. That shows the interest in this area. I think we know from market research and from your clinical, from our market research and your clinical experience, is about 10% of the procedures. Probably, I take that back. Your clinical experiences may be skewed because you are the specialist in the oculoplastic area. On an average, we see in aesthetics, we've run these surveys over the last decade or so, about 10%. People always tell us, look, I'd love to treat the area, but I'm not too sure of the complications. I've heard it's an unforgiving area because there is no deep. There is only one plane, so people don't understand that, or they don't know how to correct, undertreat, overtreat. So there's lots of, I suppose, learning points for people that you have carefully taken through. The questions are a reflection of people thinking through again and again. I'm very pleased to announce that this is going to kick off the teoxan Asia Pacific Teams campaign. We call it Illuminate Your Look. And as part of this campaign, Melanie, Jacqueline, Christoph, and Jay